Hello friends, myself Dr. Ankit Chauhan. I am Assistant Professor at UNMICRC Institute of Cardiology and Research Center. Today we are continue with our ECMO series and today's topic is blood and blood product transfusion in ECMO patient. Why needed during ECMO? The reason for transfusion during ECMO are to counteract hemodilution, to replace any blood loss or to replace clotting factors, as most of the patients on ECMO are in some degree of consumption coagulopathy. To maintain higher hematocrit in VV ECMO, especially if saturation is less than 85%, to maintain oxygen delivery. The threshold for blood transfusion is different in patient on ECMO as compared to other critical care patients, and to balance between thrombotic tendency and bleeding tendency at the same time has to maintain good hematocrit level. Threshold for blood and blood product transfusion. For whole blood, the threshold for transfusion is massive blood loss, or whenever we are initiating the ECMO during priming or replace the whole blood due to active blood loss, we have to replace with the whole blood. Packed cell, when hematocrit level less than 30 in VA ECMO and less than 35 in VV ECMO, and the replace goal of the PRBC transfusion is replace hemoglobin, and the usual dose is 5 to 15 ml per kg. For platelet transfusion, the threshold for transfusion is whenever platelet count less than 30,000 if no bleeding, and if it is less than 50,000 if bleeding is present. And our reason for transfusion is replace the platelet to stop and prevent bleeding, and the usual dose is 10 cc per kg or 1 unit per 5 kg. Cryoprecipitate, the threshold for transfusion is fibrinogen level less than 100, and whenever there is we have to replace the fibrinogen, the cryoprecipitate is the method of choice, and the usual dose is 50 cc per kg or 1 unit per 7 to 10 kg. And for FFP, the indication is whenever INR is more than 2.5 or antithrombin 3 deficiency, and the reason for transfusion is replace clotting factor and replace antithrombin 3, and the usual dose is 10 cc per kg or 1 unit per 20 kg. These are the threshold for transfusion of blood and blood product in ECMO patient. Now coming individually, whole blood transfusion. It composed of RBC, WBC, platelet, plasma and anticoagulant or preservative. It is around 63 ml per bag. It can be stored at 4 degrees Celsius up to 35 days. It is used in the case of massive blood loss when one wants to supplement all component of blood and for exchange transfusion or for priming ECMO circuit. The advantages are supplement all the clotting factors and platelet along with RBC, and which thereby decreasing the bleeding incidence, and exposure to donor is less as compared to the component transfusion. Whenever we give different component, the different donors, so the multi exposure is there. For while we choose whole blood, only single donor is there. Disadvantages are its availability and cost, and hematocrit is lower as compared to packed cell, and the platelet lifespan is only 3 to 4 days. So the older the blood, the platelet is no use of this whole blood. 1 unit of whole blood can increase the hemoglobin concentration by 0.75 to 1 gram per dl. Blood components. The blood components can be prepared from whole blood collection by differential centrifugation or directed from donor by apheresis. For different component, we have different apheresis technique. The component that can be derived from whole blood are RBC, platelet, WBC, plasma and plasma extract, which include FFP, cryoprecipitate, plasma protein fraction like albumin, immunoglobulin, coagulation factors like factor 8, 9 and TD and growth factors. Now coming to PRBC, packed red blood cell. It contains red blood cell with hematocrit around 55 to 70%. It indicated in case of anemia and in VV ECMO to keep high hematocrit. The usual dose is 10 cc per kg, which increase hemoglobin by 2.5 gram per dl, whereas whole blood will increase the hemoglobin by 1 gram per dl. Maximum dose is 15 to 20 cc per kg can be given to hemodynamically stable patient, and it is transfused over 2 to 4 hours. It can be stored at 4 degrees Celsius for 21 to 35 days and can be extended to 42 days, depend upon the preservative. Leukodepletion filter is used routinely to decrease the allergic reaction, and advantages is its easy availability, higher hematocrit level, and minimal disease transmission like cytomegalovirus. Fresh frozen plasma. Main indication is to replacement of coagulation factors, like in case of coagulation factor deficiency, fibrinogen replacement, DIC, liver disease, exchange transfusion like plasmapheresis, massive transfusion, and antithrombin 3 deficiency. The standard dose is 10 cc per kg or 1 unit per 20 kg, and it increases the factor activity by 20%. It is separated from whole blood and quickly frozen, and it should be stored at -18 degrees Celsius and thawed upon order, and once thawed expire in 24 hours. Plasma should be recipient RBC ABO compatible, and RH compatibility is usually not necessary, but in children it should also be RH compatible. And during ECMO, while transfusing FFP, heparin dose need to be adjusted. Cryoprecipitate, it contains fibrinogen, factor 8, von Willebrand factor, factor 13, and fibrinolactin. Typical dose is 15 ml or 1 unit per 7 to 10 kg. Indicated in fibrinogen deficiency or dysfibrinogenemia, von Willebrand disease, factor 8 or 13 deficiency, and DIC. Also required during ECMO due to dilution of fibrinogen upon initiation. It will increase fibrinogen and some clotting factor. 1 unit should increase fibrinogen level by 50 mg per dl for 10 kg child. ABO compatibility is preferred but not limiting, and it should be given in 5 minutes, and it also required adjustment in heparin dose during ECMO. Platelet, it is available in two forms. Platelet apheresis of single donor plasma platelet or platelet concentration regular. One apheresis unit contains 6 to 8 platelet unit from a single donor. Platelet transfusion is quite commonly required during ECMO due to dilution or due to circuit exposure to platelet, which increase platelet consumption. The usual dose of SDP is approximately half unit for less than 40 kg, 1 unit for more than 40 kg, and for smaller children it should be 5 to 10 ml per kg. It can be stored up to 5 days at 20 to 24 degrees Celsius with constant agitation to prevent clumping. Pooled platelet prepared in open system must be used within 4 hours after pooling. ABO compatible platelet are ideal, but this is not limiting. RH antigen are not present on platelet, but few RBCs are present in platelet unit, and it may sensitize the RH negative patient. SDP will increase the platelet around 30 to 50,000, and it should be administered over 20 to 40 minutes. It also required adjustment in heparin dose. Antithrombin 3. Antithrombin 3 is a physiological inhibitor of coagulation, and it inhibits factor 10A and thrombin. It enhances heparin activity more than 100-fold. Antithrombin 3 levels are developmentally low in neonate and even lower in sick neonate. Administered result in less heparin use and fewer complications. Antithrombin 3 concentrate are not readily available in many countries. In absence of antithrombin 3 concentrate, FFP is being used to supplement antithrombin 3, and the ideal dose is desired level, which is around 120 minus measured value into weight in kg. Now this component has storage and preservative limitation. For anticoagulant and preservative or additives are required for storage of blood and blood products. They give a unit a longer self-storage life. The storage solution which are being used are CPD, CPD2D, CPDA1, and they contain chemical citrate, phosphate, dextrose, and adenine. Citrate is anticoagulant and prevent clotting by binding to calcium ion. Phosphate helps to prevent pH changes and maintain normal level of ATP in blood. It also helps to maintain the level of 2,3-DPG. Dextrose helps to maintain the viability of RBC, and adenine is also added to maintain the high level of ATP so as to increase the life of the cell, and it increases the lifespan of storage component up to 42 days. These are different preservative CPD, CPDA1, CPD and additive solutions, and which increases the life from 28 days to 42 days. Now, what are the problems with stored blood? The risk of storage lesion are increased with the number of days of storage increase. The most common storage lesion are lactic acidosis, hyperkalemia, reduced 2,3-DPG in blood, and release of cytokines if they contain white cells. Most of these lesions are due to hemolysis, anaerobic glycolysis, and loss of RBC nitric oxide bioactivity. WBC present in the stored blood release cytokine which cause febrile non-hemolytic transfusion reactions. In various studies, it was found that transfusion of red cell that had been stored for more than 2 weeks are associated with significant increase in the risk of post-operative complications as well as reduced short-term and long-term survival. The relative risk of post-operative death increased by 30% in patients given blood that has been stored for more than 2 weeks, and it is associated with increased risk of infection and ischemic changes. The adverse effect of stored blood can be reduced by washing all PRBC before transfusion, use of leukocyte reduction filter, and use of gamma irradiation. PRBC or platelet can be washed with saline and it removes all traces of plasma, and it is indicated to prevent recurrent or severe reaction. But the washed RBC must be used within 24 hours and it does not prevent graft versus host disease. Gamma irradiation is a method used to destroy lymphocyte in the unit of whole blood, and it will eliminate the risk of graft versus host disease. Transfusion complications. Adverse events associated with blood transfusion therapy can be classified on the time of onset, either acute or delayed, or etiology, immune or non-immune, or infectious or non-infectious complications. Acute transfusion reactions generally occur during or within 2 hours of transfusion, and transfusion reaction manifestation may be vary with the type of blood product transfused and the clinical condition of the recipient, and it is classified in 3 categories: acute transfusion reaction, chronic transfusion reaction, and transfusion related infections. The acute transfusion reactions include acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, allergic reaction, TRALI, that is transfusion related acute lung injury, coagulopathy with massive transfusion, and circulatory overload. Delayed reaction include delayed hemolytic transfusion reaction, post-transfusion purpura, alloimmunization, transfusion associated graft versus host disease, and hemosiderosis or iron overload. Transfusion related infections like bacteremia, parasitic infection like malaria, hepatitis C, B, HIV, cytomegalovirus. Now we coming to one by one. And first, overall management of transfusion reaction. When a transfusion reaction is suspected, the transfusion must be discontinued immediately, and post reaction blood and urine sample along with the blood bag implicated in a reaction should then be sent to the blood bank for further testing. Majority of acute transfusion reaction are transient and do not require in lasting sequel. Prompt recognition and appropriate action to limit exposure, initiate investigation by the blood bank, and manage the clinical manifestation of suspected transfusion reaction is essential in minimizing the potential adverse effect of transfusion and providing quality patient care. Acute transfusion reaction, it occurs during or shortly after transfusion within 24 hours. It can be mild and non-life threatening to severe and life threatening reaction. The reaction can be immune mediated like acute hemolytic transfusion reaction, allergic reaction, febrile non-hemolytic transfusion reaction, and TRALI, or non-immune mediated like circulatory overload and coagulopathy with massive transfusion. First, acute hemolytic transfusion reaction. it can prove fatal. Secondary to transfusion of ABO incompatible red cells, uh, this will lead to activation of complement system, which result into intravascular hemolysis and release of vasoactive amines like histamine and cytokines, which causes vasodilatation, hypotension, shock, and contraction of the bronchial or intestinal smooth muscles. Intravascular hemolysis, which lead to DIC and acute renal shutdown. These catastrophic consequences can be observed with transfusion of as little as 10 to 15 ml of incompatible blood and characterized by fever and chills, hypotension, flank pain, oliguria, hemoglobinuria, and hemoglobinemia. In anesthetized recipient, the red urine or microvascular bleeding like DIC may be the only observation of this manifestation. Laboratory finding will suggestive of hemolysis like hyperbilirubinemia, elevated LDH, abnormal DIC panel, and altered renal parameter. It is critical to maintain adequate urine output with fluids and diuretics. For treatment of hypotension, low dose dopamine is preferred. For this kind of reaction, symptomatic treatment is the main goal of treatment. It also arise from non-immune in vitro hemolysis use of non-isotonic IV solution, heat, cold or mechanical state and is most often manifested by asymptomatic hemoglobinuria and tend to be self-limited and usually resolve, and maintenance of adequate renal perfusion is the focus of treatment. Second, febrile non-hemolytic transfusion reaction. It is characterized by fever with or without chills, rigors, hypertension, tachycardia and dyspnea. The symptom most often present towards the end of transfusion or within 2 hours post transfusion. Occurs due to cytokines either released in vivo by interaction of the recipient's preformed anti-leukocyte antibody with white cell present in transfused blood component or from passively acquired cytokine present in the blood product. It is usually self-limiting and treatment is to stop transfusion and give antipyretics. In those patients with repeated reaction, it may be beneficial to pre-medicate with antipyretics and or use leukoreduced blood products either by washing or by giving leukocyte filter. Allergic reaction, it may be due to plasma protein or blood preservative or anticoagulant. It present with urticaria and wheezing, and the reaction ranges from mild itching and urticaria to generalized reaction with bronchoconstriction, hypotension and shock. Generalized allergic reaction occur less frequently and in rare cases can progress rapidly, full-blown anaphylactic shock. It can be occur with as little as 5 ml of blood component transfused, antihistamine, steroid, and in severe cases epinephrine are the useful in treatment or prevention of this reaction. TRALI, it is a clinical syndrome similar to ARDS and occur 1 to 6 hours after receiving plasma containing blood products. It is caused by WBC antibody present in donor blood that result in pulmonary leukostasis. The donor HLA antibodies activate recipient complement protein that damage endothelial lining of the pulmonary microvasculature, which causes pulmonary edema. It is characterized by marked dyspnea, hypoxemia and bilateral non-cardiogenic pulmonary edema. Fever and hypotension may also be present. A patient classically require ventilation support for 3 to 4 days followed by resolution of symptoms, and steroid may be useful. Circulatory overload most often manifest as cardiogenic pulmonary edema secondary to rapid infusion or large volume infusion in a patient with cardiorespiratory compromise. Respiratory distress and hypertension are seen during or shortly after transfusion. These patients usually respond to diuretic and respiratory support with resolution of symptoms, and usually seen in elderly patients or pediatric patients or those who already has some cardiac disease or renal disease or they are severely anemic. Massive transfusion causes coagulopathy. Coagulopathy is caused by failure to replace the plasma. It can also due to calcium deficiency or excessive breakdown of store RBCs. Delayed transfusion reactions. It occurs after 24 hours and up to 2 to 3 weeks of transfusion. The different types of delayed reaction include delayed hemolytic transfusion reaction, post-transfusion porphyria, alloimmunization, and transfusion-associated graft versus host disease and iron overload. First, delayed hemolytic transfusion reaction. It is non-life-threatening reaction and usually occur approximately within 2 weeks of blood transfusion. It can be primary or secondary. In primary response, the newly formed antibodies in recipient plasma attack donor RBC, and in secondary response, the antibodies that are already present in the recipient are directly against the red cell antigen of donor. The secondary response takes place within 3 to 7 days. Both of them characterized by drop in hemoglobin and mild jaundice and usually don't require any treatment. Post-transfusion porphyria, it is non-life-threatening reaction that occur in 7 to 10 days following blood transfusion in sensitized patient like previously transfused or multiple pregnancy, and it characterized by severe drop in platelet count. It is seen in patients who already has antiplatelet antibody formed either due to previous transfusion or pregnancy, and the treatment is to give steroid and in severe cases either plasmapheresis or IVIG. Transfusion associated graft versus host disease. It occurs within 8 to 10 days of transfusion in an immunocompetent individual receiving blood transfusion from immediate blood relative or identical blood donor. Mainly seen in infant and bone marrow transplant patient who is immunocompromised. It is characterized by diarrhea, skin rashes or bone marrow aplasia which causes pancytopenia. It is usually fatal and there is no specific treatment available. It can be prevented by irradiation of donor blood to remove the lymphocyte. Hemosiderosis, condition of iron overload which occurs due to multiple blood transfusion. Iron can be deposited on vital organs and lead to organ failure. The most commonly involved organ is liver, and treatment is to give deferoxamine, chelating agents which bind with excess iron. Now, transfusion associated infections, which include bacterial, viral and parasitic infection. Bacterial infections transmitted with the transfusion are gram-positive organisms like Staphylococcus, Streptococci, usually seen in platelet transfusion, and gram-negative organisms like Yersinia, Enterococci, which seen with PRBC. It is seen more with platelet transfusion, and the risk of infection increases as the blood products are older. Bacterial infection is severe and can even result in mortality. Viral infections commonly involve like hepatitis C, hepatitis B, HIV, Epstein-Barr and cytomegalovirus. Parasitic infections include malaria, toxoplasmosis and trypanosomiasis. In summary, as a ICMO specialist, should have enough knowledge of how to manage hematological issues, how to minimize the need of transfusion and transfusion related adverse reactions, and when and what to transfuse. The proper storage and preservation of blood and blood product will minimize the adverse reactions. Thank you.